Good morning, everyone. Thank you for the introduction, Dr. Chow. Today I'm going to speak about infective endocarditis, and this is going to be a case-based discussion. And recently, we have had a lot of infective endocarditis cases with complications. So I thought maybe speaking about that will shed some light on that in this important subject. So actually, I will start with one of the most important people when it comes to infective endocarditis, and that's Sir William Osler. And he said that in 1893 that infective endocarditis increased the physician interest in the development of an infectious process. So the objectives of my talk is first to discuss the historical perspective of infective endocarditis, review the diagnostic criteria of infective endocarditis, and explain the echocardiographic findings in infective endocarditis, and then we'll have a case-based discussion of infective endocarditis and complication. So as a historical perspective for infective endocarditis, one of the first description of cardiac pathological alteration come from Professor of Medicine in France, University of Montpellier, Lazare Riviere in 1646. He was consulted by a patient who was complaining of palpitations. So Riviere detected the following sign. When I placed my hand over his heart, I detected a faint, rapid, irregular palpitation. A month later, the patient was suffering from respiratory problems and swollen legs, and the patient condition progressively worsened, and his difficulty in breathing increases, and there was no pulse at the wrist. After the patient died, Riviere performed an autopsy, and in the left ventricle he found what he described as small round outgrowth resembling a lung in texture. One of the English pathologists, Burns, in his description of an autopsy, he noted that the left auricle, the left atrium, contained a concretion larger than a pigeon egg. This substance was of an irregular form. It appears as if it has been composed of several portions of forcibly pressed together. It was of a firm consistency but somewhat friable and of a granular structure, and it adheres firmly to the side of the cavity. Um, Lewis and Grant were the first to link transient bacteremia with deformed valves as the two predominant risk factors for infection. And of course, the introduction of penicillin marked the first successful therapy for this otherwise considered a lethal infection with 100% fatality. And you cannot talk about infective endocarditis without, as I mentioned, Sir William Osler. He was linked to infective endocarditis, and even the disease were called Osler disease, and one of its peripheral manifestation, which is until now, is Osler nodes. His knowledge, based on his being a good observer, contributed to construct a unified view of infective endocarditis. He perceived that there were simple cases of infective endocarditis and there were more complex ones, and therefore used discriminative terms such as ulcerative, malignant, septic, and biemic. He established that blood elements such as fibrin and platelets deposited on the damaged endocardium, they were the substrate of the non-bacterial thrombotic endocardiopathy, and it constituted the nucleus of a vegetation. Osler called attention to the diversity of microorganisms involved in the vegetation, and he collected evidence in favor of primary characteristic of the presence of germs as in etiopathogenicity of the infective endocarditis. And at the time where the detection of living organism or germs in blood culture was just started. And that was actually published in the British Medical Journal. And Osler said at that time the protein uh, character of the malady, the latency of the cardiac symptoms, and the close simulation of other disorder combined all of these factors to render the detection of infective endocarditis difficult. And this still exists till now, where many cases of infective endocarditis were missed, and they were diagnosed with other pathologies like pneumonia, sepsis, other type of infection, and the diagnosis of infective endocarditis only reached after like few days of investigations. And going back to the historical background of echocardiography of vegetation, in 1970, the publication of the articles emphasizing the disclosure of vegetation by M-mode echocardiography were all over that decade. In 1980, J. Stewart from Duke University, he summarized the state of art at the time, and this is what he said. Although it's a good method to document the presence or absence of infective endocarditis, it does not seem to be reasonable to use echocardiography as a routine diagnostic method, as only half of the patients that meet the clinical criteria manifest echocardiography signs. Moreover, the vegetation does not regress rapidly, and thus echocardiography might have a low diagnostic power in patients with history of infective endocarditis. And to be fair to him, this was in the era of really where M-mode was mainly main the main echocardiographic tool at that time. 10 years later, Duke University, they gave another magnificent contribution to the knowledge of infective endocarditis through a diagnostic systemization that elevated echocardiography to be a major criteria in diagnosis of infective endocarditis. And what we know that now that echocardiography in all the guidelines is the first tool to diagnose infective endocarditis and the most important tool to diagnose infective endocarditis. So just generally, so that was historical aspect of infective endocarditis. Now let's talk about some infective endocarditis statistics. It's a disease with an annual incidence ranging from 3 to 7 per 100,000 person per year in most contemporary population surveys. Although relatively rare, infective endocarditis continues to be characterized by increased morbidity and mortality, and it's now the fourth most common life-threatening infection syndrome after sepsis, pneumonia, and intra-abdominal abscesses. Globally, in 2010, infective endocarditis was associated with 1.5 million disability-adjusted life years, or years of healthy life lost, as a result of death and non-fatal illness or impairment. Always, when you think about infective endocarditis diagnosis, you always remember the modified Duke's criteria. And these criteria classify infective endocarditis into three categories: definitive endocarditis, possible infective endocarditis, and rejected infective endocarditis. Definitive, when either you have a pathological criteria like microorganism demonstrated by a culture or an histological examination of vegetation, a vegetation that has embolized, or an intracardiac abscess specimen, or pathological lesion like vegetation or intracardiac abscess confirmed by histological examination showing active endocarditis. Clinical criteria combine either two major criteria, one major criterion and three minor criteria, and five minor criteria. Possible infective endocarditis when you have one major and one minor, or three minor criteria. Rejected infective endocarditis when you have a firm alternative diagnosis or resolution of symptoms suggesting infective endocarditis with antibiotic therapy for less than 4 days, or no pathological evidence of infective endocarditis at surgery or autopsy with antibiotic that was given for less than 4 days, or if the patient does not meet any criteria for possible infective endocarditis. European Society of Cardiology 2015 added more criteria to diagnose infective endocarditis. So the right side here, you can see that if you have a clinical suspicion of infective endocarditis, you apply the modified Duke criteria. So if you get definitive infective endocarditis, then you have your diagnosis. If you got possible or rejected infective endocarditis, but you still have high suspicion, If it's a native valve, you repeat echoes or you image for embolic event, and that imaging include cerebral MRI, whole body CT or PET CT, or you do cardiac CT. If it's a prosthetic valve, you repeat the echo, or you add FDG PET CT or leukocytes labeled SPECT, cardiac CT, or imaging also of an embolic event. If you reject, then that's it. So what they added in the 2015 criteria, so they have major criteria and minor criteria. So let's go one by one. So the major criteria, which is almost similar to the modified Duke's criteria. So if you have blood culture that's positive for infective endocarditis, so you have typical microorganism consistent with infective endocarditis from 2 separate blood cultures, and these typical organisms are Strep viridans, Strep galacticus, which is used to Strep bovis, Hasseck group, or Staph aureus. Or you have community acquired enterococci in the absence of primary focus. Or you have a microorganism consistent with infective endocarditis from persistently positive blood culture. So more than 2 positive blood culture with blood sample drawn more than 12 hours apart, or all of 3 or majority of 4 separate culture of blood with first and last sample drawn more than 1 hour apart. Or you have a single positive blood culture for Coxiella burnet and phase 1 IgG antibody titer 1 to 800. Imaging positive for infective endocarditis include echocardiography. So if you have echocardiography positive for infective endocarditis, like vegetation, abscess, pseudoaneurysm, intracardiac fistulas, or you have valvular perforation or an aneurysm, or a new partial dehiscence of prosthetic valve. What's new about the European guidelines is that they added abnormal activity around the site of prosthetic valve implantation detected by FDG PET and CT, and that's only if a prosthesis was implanted more than 3 months, because if you do it within 3 months you may have false positive result, or radio-labeled leukocyte SPECT CT, or you have by CT scan definitive paravalvular lesion. Minor criteria include predispositions such as predisposing heart condition or injection drug user, fever defined as temperature more than 38, presence of vascular phenomena which include those detected by imaging only. So that's another addition where you get vascular phenomena as detected by imaging. So major arterial emboli, septic pulmonary infarct, infections like mycotic aneurysm, intracranial hemorrhage, conjunctival hemorrhage, and Janeway lesions. Immunological phenomena such as glomerulonephritis, osseous nodes, Roth spots, and rheumatoid factor. Or microbiological evidence positive blood culture but does not meet the major criteria as noted above, or serological evidence of active infection with organism consistent with infective endocarditis. So the role of echo when it comes to infective endocarditis. So as I mentioned before, TEE, transthoracic echo, is recommended as the first line imaging modality in suspected infective endocarditis. So it's a class 1B. And TEE is recommended in all patients with a clinical suspicion of infective endocarditis and negative or non-diagnosed transthoracic with a class 1B. And TEE is recommended in patients with a clinical suspicion of infective endocarditis when prosthetic valve or intracardiac device is present with a class 1B. Repeat transthoracic or transesophageal within 5 to 7 days, and that is different from the previous guidelines. So it's a shorter repetition days. So 5 to 7 days is recommended in case of initially negative exam when you still have a clinical suspicion of endocarditis, and that's class 1C. Echocardiography should be considered in Staph aureus bacteremia, class 2A, and TEE should be considered in patients with suspected endocarditis, even in cases with positive transthoracic echo. And the exception of that, when you have isolated right-sided native valve infected endocarditis, and you have a good quality transthoracic echo with unequivocal echocardiographic findings. And then a follow-up patient with medical therapy, so you should repeat transthoracic or transesophageal as soon as new complication of infective endocarditis is suspected, like patient having new murmur, embolism, persisting fever, heart failure, abscess, or a new heart block. So when you have a clinical experience with that infective endocarditis, you go to transthoracic echo first. If you have a negative transthoracic echo and then you should judge your clinical suspicion. If it's still high, you should go for TE. If low, then stop. If the transthoracic echo is positive, then you go for TE, with the exception, as I mentioned, of right-sided infective endocarditis with good quality of transthoracic. Or you have non-diagnosed. If it's not prosthetic valve or intracardiac device, you should go for TE regardless. And if, as I said, if the initial TE is negative, but you still have high suspicion, you should repeat within 5 to 7 days. In the American guidelines, it's almost the same. So echocardiography as soon as possible, less than 12 hours after initial evaluation. TE is always preferred over transthoracic echo. And repetition, here they mention 3 to 5 days after initial TE if suspicion still exists. Or TE after positive TE as soon as possible in patients with high risk for complications. And one of the guidelines that recommended that transthoracic echo at the time of antimicrobial therapy completion to establish baseline feature is reasonable. So you do transthoracic echo at the end of medical treatment of infective endocarditis, and that's class 2A. So when it comes to echocardiographic description of infective endocarditis, it's characterized by a combination of vegetations, destructive lesion, and abscess formation. So a vegetation is a clump of infected material consisting of fibrin, platelets, and white blood cells and microorganisms. So they appear as abnormal echogenic mass. So as you can see here in the aortic valve, so it's an echogenic mass attached to the valve leaflet, and if you play the video, you'll see that they have independent mobility, and usually they are attached to the low pressure side of the valve, which is in the aortic valve is in the LVOT side, in the mitral valve it's in the left atrium side. But they can be attached anywhere, so that's not the rule. So when you have, they can be attached on the valvular side, subvalvular apparatus, also mural endocardium, and even in the ascending aorta. So you can see them everywhere, but their usual site of attachment is the low pressure side. And when they are large, they are prone to embolize, and they are less frequently to cause valve or prosthetic obstruction, although there are cases of obstruction of the valve with this vegetation. So the sensitivity for transthoracic echo for the diagnosis of vegetation is about 75%, but it may be reduced in case of either low echogenicity, very small vegetation, and infective endocarditis affecting intracardiac device or prosthesis. So when you add TEE to transthoracic echo, it increases the sensitivity to 85 to 90%. Specificity for both transthoracic and transesophageal echo are both high. It's around 90% for both. And the reason that, as I mentioned, we have false negative echoes sometimes, either you have a poor acoustic windows, when the vegetation is less than 3 millimeters, when you have recent embolization, or you have non-oscillating vegetation, when you have atypically located vegetation, or pre-existing cardiac lesions like calcification or degeneration or sclerosis, the presence of prosthetic valve or intracardiac device. All these are reasons why sometimes you have a false negative echo, and always you should think of repeating echo whenever you think that you have a high suspicion of infective endocarditis. Destructive lesions. So destructive valve lesions are frequently associated with vegetation, but they can be observed alone. So you may have severe valve destruction, an AI, and you cannot see any vegetation. So this form of destructive lesion may provoke valve aneurysm, perforation of the valve, prolapse, colder rupture, or less frequently even BAP muscle rupture. And the usual final consequence of these lesions are severe valve regurgitation or heart failure. The third manifestation of infective endocarditis is abscess formation. So abscess typically present as a perivalvular zone of reduced echo density without color detected in sites, so if they are not complicated. And the diagnosis is easy in the presence of clear free space in the aortic root, but may be much more difficult at early stage of the disease when your only clue of presence of an abscess is thickening. And so they are more observed in the aortic valve and usually involve both. When it's in the aortic valve, they extend into the mitral aortic intervalvular fibrosa, and they are more frequent in prosthetic valves. And the sensitivity of transthoracic for diagnosis of abscess is only 50% compared to 90% for TE. But the specificity when you detect an abscess or thickening on transthoracic echo or transesophageal echo is 90%. So just some description, anatomical and echocardiographic definition. As I mentioned, vegetation is an infected mass attached to the endocardial structure, and they look at the oscillating or non-oscillating endocardic masses on valve or other endocardic structure or implanted intracardiac material. Abscess is a perivalvular cavity, and they look at they are thickened non-homogeneous perivalvular area with echodense or echolucent appearance. Pseudoaneurysm is one complication that is described as perivalvular cavity communicating with a cardiovascular lumen. So when in echo you see them as pulsatile perivalvular echo-free space with a color Doppler flow detected, and that's how you differentiate them with abscesses. Perforation is an interruption of endocardial tissue continuity, and they are usually detected by color Doppler flow, although you may see 2D gaps. Fistula is a communication between two neighboring cavities through a perforation. So a color Doppler communication between two neighboring cavities through a perforation, that's what you see in echo. Valve aneurysm, when you have a saccular outpatching of the valvular tissue, and that's what you see in an echo. Then the dehiscence of the prosthesis, when you have paravalvular regurgitation identified by TE, or so it's either associated with rocking motion or no rocking motion. Finally, I will talk about prosthetic valve endocarditis. And prosthetic valve endocarditis is the most severe form of infective endocarditis, and it occurs in 1 to 6% of patients with valve prosthesis. Accounting for 10 to 30% of all cases of infective endocarditis, with similar incidence observed in mechanical and bioprosthetic valves. The pathophysiology differs from that of native endocarditis in several aspects. It's characterized by lower incidence of vegetation, so you don't see more vegetation when it comes to prosthetic valve, but then you see more incidence of abscess and perivalvular complication. And the usual consequence is a new prosthetic regurgitation and heart failure, and less frequently large vegetation may cause prosthetic valve obstruction. So these diagrams will show us the difference between two types of prosthetic valve. So you have the mechanical prosthetic valve and bioprosthetic valve. And so the anatomical involvement is different. So when it comes to mechanical, they usually involve the junction between the sewing ring and the annulus. So they lead usually to perivalvular abscesses, dehiscence, pseudoaneurysm, and fistulas. In bioprosthetic infective endocarditis, they are more frequently located at the leaflet themselves, so they lead to cusp rupture, perforation, and vegetation. So in this image, as you can see, so this patient has a form of infective endocarditis and prosthetic valve, and the clue for that was the presence of a paravalvular leak. And this mass, you can see the patient has large vegetation that's obstructing the flow in the prosthetic valve. The cardiac device related infective endocarditis, the incidence of infection of these devices varies widely among studies. A recent population-based study found that incidence is almost 2 per 1,000 devices per year. The probability of infection is higher after ICD when compared with pacemaker. A vegetation may be attached to the electrode lead, the tricuspid leaflet, and the endocardial wall. Lead vegetation may have a sleeve-like appearance and are difficult to distinguish from a thrombi, and TE has higher sensitivity and specificity compared to transthoracic echo when it comes to cardiac device-related infective endocarditis. The difficulty of detecting lead vegetation by TE are explained by the following reason. So, a presence of reverberation lead echoes, especially in patients who has multiple intracardiac leads. Or sometimes you have an atypical location of vegetation. You see the vegetation with the superior vena cava or the right atrium. Therefore, always when you have a normal echocardiographic examination, you do not rule infective endocarditis when the clinical suspicion is high. And always think of repeating a TE if it's negative within 7 days, 5 to 7 days. And these are examples of pacemaker lead infective endocarditis. So in this case, you have a clear vegetation attached to the pacemaker lead. But in other cases where you have these sleeves like covering the lead, where you are not sure is this thrombus or a vegetation. So the guidelines when it comes to cardiac device related infective endocarditis, so you have to have 3 or more sets of blood culture before initiation of antimicrobial therapy. Lead tip culture is always indicated when the device is explanted. A TE is recommended in patients with suspected lead-related infection with positive or negative blood culture independent of the result of transthoracic echo to evaluate lead-related endocarditis and heart valve infections. Intracardiac echocardiography may be considered in patient that has positive blood culture but negative TE and transthoracic echo, and the use of radio-labeled leukocyte scintigraphy and FDG PET may be considered. So both 4 and 5 are class 2B. The use of 3D echo is increasing, and real-time 3D TE allows analysis of 3D volume of cardiac structures in any possible plane. So they have better evaluation of presence of vegetation, size, morphology, and even better prediction of the embolic risk. So it's useful in assessing also perivalvular extension of the infection, or dehiscence of prosthetic valve and valve perforation. And as we know, TE or 2D TE could underestimate vegetation size depending on the plane that you are cutting through the valve compared to the 3D TE. So these are examples of vegetation as seen on 3D. And as you can see here, so you have multiple vegetation attached to the mitral valve posterior and anterior leaflet. And then this is another example of vegetation from the, if you are looking at the mitral valve from the atrial side, and as you can see, large vegetation attached to the mitral valve. Again, prosthetic valve 3D is really useful, and as you can see here, dehiscence of prosthetic valve, and also here you see that the prosthetic valve has a large area of detachment of prosthesis and dehiscence on the anterolateral side. This is another example of non-infective thickening, where you see in the patient with Liebman sac endocarditis, and you can see clear thickening on the tips of the mitral valve, differentiated that from the vegetation related to infective endocarditis in a patient. This is in a patient with SLE. So last slide, then I will go to the cases. So indication and timing of surgery in left-sided native valve endocarditis. So we have 3 main indications. So the presence of heart failure, presence of uncontrolled infection, or prevention of embolism. So when it comes to heart failure, emergency class 1 is when you have aortic or mitral infective endocarditis, severe regurg or valve obstruction, and that's causing refractory pulmonary edema or cardiogenic shock. Then you have another emergency indication. So when you have an aortic or mitral infective endocarditis with fistula into a cardiac chamber or pericardium, and that's causing also refractory pulmonary edema or shock. Urgent indication when you have an aortic or mitral infective endocarditis with causing heart failure, but the patient is not in shock, but he's showing not in refractory shock, but he's showing signs of persistent heart failure or echocardiographic signs of poor hemodynamic tolerance. When you have no heart failure, then that's an elective indication of the surgery. Uncontrolled infection is an indication as urgent when you have local uncontrolled infection like abscess, false aneurysm, fistula, enlarging vegetation, or when you have persistent fever and positive culture more than 7 days after starting antibiotic, or when you have an infection caused by fungi or multi-resistant organisms. Prevention of embolization, so when you have an aortic or mitral infective endocarditis with a large vegetation more than 10 millimeter, and the patient developed an embolic phenomena despite antibiotic therapy, that's an urgent indication of therapy. Also, when you have an aortic or mitral infective endocarditis with large vegetation and other predictors of complication course like heart failure, persistent infection, and abscess, this is an urgent. And when you have an isolated, very large, more than 15 millimeter, this is an urgent with class 2B. So let's start now with the cases that we prepare. So we'll just go through the cases. So the first case is a 59-year-old male. He has history of anemia and TB exposure a long time ago. He presented with drenching night sweats, cough, short breath, and he was nauseating and he has vomiting. And that was actually for 3 to 4 weeks before that. He was admitted as a case of fever of unknown origin. So he was started in, they did not start antibiotic immediately, but they sent for cultures. And when the culture came back for Streptococcus mitis infection, they asked for transthoracic echo. This is the echo, transthoracic echo, and this is parasternal long axis view. And as you can see, LV function seems normal, but the aortic valve, what you can see is that there is a significant thickening of the aortic valve, and it looks like thickened and calcified. And added to that, so we'll talk about the morphology of that later on, but let's go to, when you look at color, you started to notice that the patient has severe aortic regurgitation. And as you look at these valves, it looks like that aortic cusp looks like it's prolapsing into the LVOT during diastole, with partial prolapse of that anterior aortic leaflets. And so when you go and you look at, this is zoomed view and it's showing what we are describing. So as you can see, there are small vegetation attached, but it's mainly that the valve is not functioning well. So this is the short axis view, and as you can see that the valve patient looks like he has a bicuspid aortic valve, and most likely that's the predisposing structural thing on the aortic valve that caused the patient to develop infective endocarditis. And as you can see, flow that's continuous through systole and diastole, and that's severe AI seen also here. This is an apical 3, and then you can see here there is a clear vegetation attached to the posterior aortic cusp here, and prolapsing into the LVOT during diastole. And this is the color, and you can see that clearly there is severe AI. The LV is not dilated yet, and that's showing maybe this is an acute process, and the LV did not have time to dilate yet. So this is an apical 5, and as I mentioned, there is big vegetation, as you can see here, with severe AI. And this is the Doppler, as you can see here in the abdominal aorta, and you can identify here that the patient has flow reversal in the abdominal aorta consistent with severe AI. Again, a flow reversal in the descending thoracic aorta also associated with severe AI. So this is the transesophageal echo. And as you can see here, as I mentioned before, there is masses attached to the both leaflets. There are prolapse of the posterior, so this is a posterior now because we are TE, prolapsing into the LVOT, so the valve is like flail valve, and that with like a gap, explaining the severe AI in this patient. And this is the color, and as you can see, a large vena contracta and severe AI. And as you see in this image, you started to identify there is thickening on the aortic root, and that thickening is extending toward the mitral aortic intervalvular fibrosa. So this is a diagnostic of presence of an abscess, and there is an echolucens cavity within that abscess. And this is the short axis view of the aorta, of the aortic valve. And as you can see here, the clear vegetation and the bicuspid aortic valve, and there is thickening also here and there, which can also point toward diagnosis of presence of an abscess. So the patient went for surgery, and as you can see in the surgery, they confirmed the presence of bicuspid aortic valve. It was removed entirely, and they did a Management of Endocarditis mass infiltrating the annulus at the level of the commissure between the left coronary and non-coronary cusp. And in this stage, they were able to see that there is an aortic root abscess, and there is a cavity infiltrating the base, especially the left coronary leaflet, and into the anterior leaflet of the mitral valve. So what they did is the aortic valve replacement with stented bioprosthesis. They used a Magna Ease size 25. They repaired the aortic annulus abscess with pericardial patch, and they repaired the anterior mitral leaflet with a patch. So case 2 is a 65-year-old female who was admitted to another hospital with recent complicated UTI and sepsis, DKA E. coli bacteremia. So she presented with congestive heart failure at this time. So in the history, it was noted that she had recent UTI, flank pain, and fevers that persisted following outpatient antibiotic therapy. She additionally had a root canal procedure in the past 3 months. So they asked for transthoracic echo. And this is the transthoracic echo. And as you can see here, there is a small pericardial effusion. There is an extensive thickening and calcification of the posterior mitral leaflet, and there is a small mass, as you can see here, on the atrial side of the valve, but we'll just look at that later on. And the function looks normal. So this is just a color compare, and as you can see, there is thickening on the posterior mitral leaflet, and there is a small mass that's attached to the posterior leaflet, and there is a highly suspicious 2D gap there. So as you can see here, there is a color jet extended there. So at the patient, there is still a suspicion of infective endocarditis which was complicated by perforation, but we'll see that later on. So this is the apical 4, and as you can see, there is thickening of the posterior leaflet and query mass there, as you can see here moving, and there is like a 2D gap there. When you put color, you can see clearly a perforation through the posterior mitral leaflet. This is the T, and this is at 60 degree. We are explaining through the mitral valve, and as you can see, there is a clear vegetation there, multiple small vegetation, and that 2D gap. So when you put color, you can see clearly a complex jet of MR. So you have a central jet of MR through the coaptation line there, and there are also another jet which through the perforation with clear Pisa. This is where 3D would be used to show the pathology. And as you can see here in the posterior mitral leaflet, we are looking from the atrium. You can see clear 2D gap and hole in the posterior leaflet, central posterior leaflet. And here you can see color through that hole, with also an MR that is also central. This is one view, a true view, that's one feature of 3D echo. And as you can see here, clearly the perforation of the mitral leaflet. And this is color going through that hole, confirming the presence of perforation. And this is the one of the pulmonary veins which shows late to end systolic flow reversal, confirming significant MR. So the patient went for surgery, and the surgical finding showed there was a hole in the posterior segment of P2 and mild to moderate MAC along the P2, P3 segment. They could not maintain the valve, so valve were excised and replaced. Case 3 is a 38-year-old male who was transferred from another hospital with infective endocarditis, and it was complicated by shock. He has a history of bicuspid aortic valve and known AI from previous group A streptococcus bacteremia in November 21, so that's 3 months before this, and he's known IV drug abuser. 2 sets blood culture at this time were positive for lactobacillus rhamnosus. So looking at this transthoracic echo, it looks different than from our first case, where here you see dilated LV cavity. LV function looks mildly to moderately reduced. There is apical tinting of the mitral valves consistent with dilated LV, and you would expect functional MR. And there is mass attached to the aortic valve that's prolapsing into the LVG during diastole. It has echogenic independent motion. So when you put color, you start to identify the presence of severe aortic regurgitation. So this is a sweep, and as you can see in this sweep, you start to identify this mass prolapsing into the LVOT. So this is a short axis view of the aortic valve, and as we know, this is patient bicuspid aortic valve. Maybe in this view it's really difficult to make sure about is it tri or bileaflet, but we'll see that in the TE. And then you see a clear aortic regurgitation jet. So this is 3D transthoracic echo. And as you can see, there is a clear vegetation, see big vegetation on the aortic leaflet prolapsing into the LVOT. And this is the apical 5, again showing the LV is dilated globular shaped and with multiple vegetation. And here also an apical 3 is showing the same finding, so LV function is reduced. And this is when you put Doppler on the aortic regurgitation, and you identify that the patient has very short pressure half time. So usually when it's less than 200, it's severe. In this patient, it's 101. Also looking at the descending thoracic aorta, you can see that flow reversal in the descending thoracic aorta, and then measuring VTI of 20. So this transesophageal echo, and this is sweep, and as you can see, there is clear vegetation on the anterior aortic leaflets, and so this is one, and there are smaller one there. When you put color, you can see that there is clear jet that's directed against the septum. But what you can identify here, there is no clear thickening of the aortic root compared to that previous patient. So this is short axis, and then we can confirm the presence of bicuspid aortic valve. Also here you can see that's a clear aortic regurgitation. Also no thickening the aortic root. So the patient went for surgery, and so they opened up the aorta and they inspected the valve. It was diffusely diseased, particularly in the right and left coronary cusp. So there was a small aortic root abscess, despite that transthoracic echo and transesophageal echo were not able to show. And so all three leaflets. So most likely the valve was distorted, actually to tri-leaflet valve rather than bi-leaflet aortic valve. Case 4 is a 79-year-old woman. She lives in a retirement home. She was admitted in another hospital with infective endocarditis. Blood culture grows strep viridans. She was treated with 4 weeks of intravenous ceftriaxone as medical therapy after discussion with the cardiovascular surgeons, and through the decision was made to make her medical therapy. She improved initially with the medical therapy, but then she started to develop progressive short breath with exertion. So she came to our structural clinic, and she was then discussed for any form of intervention for that valve. So we went ahead and we did the transthoracic echo, and as you can see in the transthoracic echo, the mitral valve looked thickened, calcified with MAC, and so especially the posterior leaflets. Again, when you put color, you can see that there is a small jet of central MR, but also there is a jet that seems like it's coming from the posterior leaflet, and that's highly suspicious of perforation. So doing a short axis view of the mitral valve, you can identify the presence of calcification, but there also this small cavity within the calcification suspicious for perforation. So that is the color compare, and as you can see, you can identify here the presence of calcification with cavitation, and there is color within that cavitation. So we went ahead and we did the transesophageal echo, and as you can see in the transesophageal echo, you identify a cavitation within the posterior mitral leaflet that looks like it dilates with systole. And when you put color, you can see the color within. So that is most likely a presence of aneurysmal mitral posterior mitral leaflet with a cavitation. So, and you can see, let's go to the next one. So when you zoomed in, you see that cavity within the mitral leaflet. So you see some 2D gap here and 2D gap here. When you put a color, you started to identify that there is actually a fistula between, so the perforation between that leaflet. So what you see here is the color there and the color going out of that cavitation. So there is a perforation of the posterior leaflet. So this is 3D was not really that useful in this study because of poor calcification. And as we know, 3D really depends on the 2D images. If you have 2D images, then you get a good 3D. So the patient at that time, so she was discussed structural. It was difficult to offer her any form of structural intervention, but she was referred to a surgeon. And after discussion with the patient, she didn't want to consider any surgery at this time due to her general condition. And this time actually was in 2019. So she was followed for 2-3 years, and she did well until recently. She was in the clinic 2-3 months ago. With still, she's complaining of short breath, but no more. So she, despite that limitation of movement, she was doing well. So case 5 is a 56-year-old male with fever, malaise, and drenching sweats at night, reduced appetite, and intermittent vomiting. So he was diagnosed with streptomatis, infective endocarditis, so complicated by right iliac artery septic embolism while he was waiting for transfer. So he underwent status post, underwent thrombectomy, and CT scan as a form of imaging, so subacute ischemic stroke. So this is the transthoracic echo, and as you can see here clearly, there is a clear mass on the anterior mitral leaflet prolapsing into the left atrium with independent motion. When you put color there, you can see that there is clear severe MR, and possible there is a perforation of the anterior mitral leaflet. So we went ahead and so this is just color compare first, and as you can see, there is what looks like a perforation of the anterior mitral leaflet with pizza and color going through it. So this is apical 4, and as you can see, big mass and also possible perforation. So this is a TE, and as you can see in this TE, you can, there is what's called a windsock deformity of the anterior mitral leaflets. So that leaflet, and then you can see also a gap there at the base of that windsock, which is suspicious for perforation. And when you put color, you can see clearly there is perforation within that cavitation within the mitral valve, aneurysmal mitral valve leaflet. Again, the same finding. So this is 120° and this is anterior mitral leaflet, and clearly you can see that deformation, windsock deformation of the anterior mitral leaflet, aneurysmal mitral leaflet with perforation. So this is a beautiful 3D, and as you can see in the 3D, you can identify that 2D gap within the anterior mitral leaflet. This is a true view, and as you can see, there is a clear gap, and there is a color within that gap. So that patient underwent surgery and they replaced the valve. So let's talk about case 6. So case 6 is a 32-year-old female who is a drug abuser. She was admitted initially to another hospital with hypoxic respiratory failure, diffuse airspace disease, developed tension pneumothorax. She was there found to have extensive tricuspid valve endocarditis and MSSA and GPS bacteremia, so multi-organisms. So she underwent, she was actually referred to us for what's called a debulking therapy of that vegetation, which is a new procedure. And So when you look at this transthoracic that we did when she arrived, you can clearly see that there are big vegetation on the anterior tricuspid leaflet that's prolapsing into the right atrium during diastole. Again, there is clear, severe TR with laminar flow. So these are the apical 4, and you can see clearly here there is a vegetation, multiple big vegetation, and the color is consistent with severe TR. Again, this is a short axis view, and this I'm just showing a big vegetation of the tricuspid valve and the color flow. So this is the transesophageal echo, and as you can see here, there are multiple vegetation on the tricuspid valve. This is the 60-degree commissure view, and you can see here clearly multiple vegetation on the all tricuspid leaflets. And this is just a color comparison. These are the vegetations and severe TR. So the patient underwent debulking of that mass. She ended up having a bad severe TR, but she survived that infection. This is a 3D of the vegetations. As you can see, multiple vegetation on the tricuspid valve. Then I will just go through 3 cases, which is interesting for me, mimickers of infective endocarditis. So this is a 58-year-old stroke workup. She's known to have a CLE, and she had the right thalamic ischemic stroke. And as you can see, the clear thickening at the tip of both mitral leaflets. Multiple thickening and small masses on the leaflet. And as you can see here, so there is a lot of thickening of the leaflet, but not a severe MR. So after ruling out infection in this patient, she was diagnosed to have a Liebman-Sack endocarditis. Case 8 is a 67-year-old female presented for assessment of aortic valve mass, an LA mass. So she was investigated, and at that time the main presentation was actually she lost consciousness during PFT study. And this is what the aortic valve look like. So you started to identify these small linear filamentous masses on the anterior and posterior aortic cusps. So when you look at this, there is no AI at all, but these small masses in the aortic valve, they mutually attach to the coaptation line of the aortic valve. And as you can see here, you had started to identify these small masses on the coaptation line of the aortic valve. And these are really highly suspicious for fibroelastoma of the aortic valve, papillary fibroelastoma. Limbals also is another differential. And then you always have to rule out infection and vegetations. This is a 3D. How does 3D look in this patient? So the patient was known to have papillary fibrostoma, and she was referred for surgery since she had stroke. And unfortunately, the surgery was not done because the patient didn't want to go through surgery. But one incidental finding in this patient is that you can also see here a mass that attached to the comadin ridge. And this mass is really a front-like projections This mass is more characteristic of papillary fibrostoma compared to the aortic valve masses. And there are reported cases of comedian ridge attached papillary fibrostomas. And this is 3D of this mass. Finally, I will end up with this case. So this is a lady that we saw, a 77-year-old female. She was referred for assessment of mass on the mitral valve. At that time, she was admitted with worsening dyspnea. Past investigator history, she was diagnosed to have stage 1 lung cancer, adenocarcinoma. It was resected in 2019, and then she presented in 2022 with suspicious lung nodules. She's known to have COPD, CKD, hypertension, dyslipidemia, and anxiety. So as you can identify here that this is a TE, this is left atrium, LV, and aorta, and there is a long mass attached to the anterior mitral leaflet, and it's like the motion of this mass is strange, like it passes through the aortic twice, then it goes into the mitral, and then it goes to the aortic, so it's following the flow. So this lady, lung biopsy was done and it shows recurrence of malignancy. She didn't want any further treatment. This is the color, not much of regurg, and there is no obstruction flow. Thank you.